My approach to treating metastatic castration-resistant prostate cancer is dependent upon the sites of disease and the symptoms. So I look first at whether a patient has visceral or non-visceral metastases. I also look at whether a patient is asymptomatic or symptomatic. For those patients with visceral metastases, I think chemotherapy is the first choice for treatment. I go, of course, with docetaxel. Second-line treatment would be cabazitaxel. There is no data for cabazitaxel in the first-line setting at this particular point. If a patient is asymptomatic, I like to go forth with immune therapy first. If they have disease that's limited to the bone, immune therapy is not appropriate for those patients who have visceral disease, nor is isotope therapy appropriate for that group of patients. But if they're asymptomatic, I'd like to go with Provenge first. There is evidence that it takes time for the immune system to mount a response, and in this situation, you want to afford the patient the maximal opportunity to receive that benefit from Provenge. Sipuleucel T is a very interesting treatment from the standpoint that it is limited to those patients who have bone-only disease and who do not have visceral metastases. And if you look at the IMPACT trial, which was the trial that got Sipuleucel T approved, there are patients who who had not had chemotherapy and who had had prior chemotherapy. In fact, 15% of patients on the trial did have prior chemotherapy. So the real issue is, if you treat somebody with chemotherapy and they have an excellent response, do you give Sipuleucel T at that point to potentially consolidate that or improve the overall outcome? I think that that's not an unreasonable thing to do, particularly if the patient has disease limited to the bone or lymph node. Again, if somebody has visceral disease, I wouldn't use that particular approach.